This is a talk on the new access model and what we're doing. The plan for this talk is to go through what we've been doing over the past couple of months, what we're doing well, we think, what we're not doing that well, and get feedback from all of you. So I'll try to have 5 or 10 minutes at the end for questions and for feedback. I wanted to start the talk by asking people, what is access? What does access mean to you, or how would you define access? And the way that the exercise that I give myself, which I often fail, is if you can explain something to like a 10-year-old, that means you understand it. And if you can't, then you probably don't understand it that well. So give me some ideas about what access is.
A big doorway to mental health.
Sweet. One doorway to mental health, a big doorway to mental health.
Getting something.
Getting something.
Getting somewhere.
Getting somewhere, like getting to a provider or getting into a system.
Yes, open your heart and open your doors, in this sentence.
Yeah, open your heart and open your doors. And just welcoming people into our system of care.
To give it in confidence.
Yep. Give it in confidence, so safety.
The first step in 1,000.
First step in 1,000. I love it. Yeah. So I looked this up to try to find out what the root of the word access is. And it's kind of cool if you look at the definitions in Merriam-Webster. The first definition is onset. It's like the first step in 1,000. It's the beginning of services. The second definition is an intense outburst, like and it's sort of like there's even like an older definition about a fit of rage. And I think that resonates so much with our system, because we're trying to have an open door, we're trying to allow for a gentle approach, and then there's also this influx of people that just desperately need services, and they come into access in sort of an outburst. So the other question before we get into what we're doing or trying to do is, if you had infinite resources, so lots of money, and you weren't going to go spend it in like a beautiful tropical island, you're actually going to use it for access, and all the staff you needed to hire, what would the perfect access system look like? What would you build?
A highway with an exit and entrance.
A highway with an exit and an entry.
Entry and exit.
That might be too metaphorical for me. Help me out. What would you build? Like, what kind of system of care would you build? What would it look like? So, go ahead, Carmen.
So I would build a place where people can come into one environment, get support. If they needed to have a therapist, there would be a therapist. If they wanted to participate in groups, there would be groups. If they needed medical attention, they would be able to get attention right away. And then also an area similar to what Ami's offering, an area where people can get support and linkage to resources. That's what
I love that system.
Art therapy, dog therapy.
One of the things that you mentioned there, the integration of primary care and psychiatry, that you go into a single place and you're getting your medical care. If it's medical care for depression or medical care for hypertension, that is actually a model, and I think it has a very sweet name. It's called something like the medical home model, and they are doing that in other parts of the country where it's combined. Yeah.
Department of Social Services has a one-stop. We should have a one-stop for mental health.
One stop for mental health. So what would it be? Like, what would that mean?
Everything. Entry point, children's services, adult services,
Cool.
referral services, whatever it takes.
Yep. Okay. I love that too. And I think that actually reflects what we're starting to build right now. Both of those do. So one way to think about what we're doing is to try to answer the question first of why change? Why are we changing things? And I know that that's been bothering people because there have been changes that have been happening, and we haven't always communicated them perfectly, and we're all kind of set in our worlds. And even though we can recognize that there are some things that need to be changed, what is the big reason for needing to make this change in access? And I can actually give you answers to this one, but Maggie, do you have an answer?
Because we all know that down the road we are going to get masses more than what we've already had. We know that unless we have a system that's thought out,
Yep.
and we're somewhat prepared, we are going to get what we think is burnout now, it's going to get worse.
Perfect. I mean, Affordable Care Act is great for the world and terrible for us, right? I mean, we know that it's great for us too because it will allow us to provide more care to people that need it, but it means that there are lots of new patients coming into our system. And if things go the way that they should, there should be more patients in the future coming into our system. So we need to prevent burnout. We need to think about something that's going to work. So I identified just 5 areas that weren't working, and I'm going to go through them, and then I'm going to tell you what we're doing to work on those areas. And there are many areas that I'm sure exist outside of these. So one thing to identify that hasn't been working is the inefficiencies in our system. Every system has inefficiencies, but we have some profound inefficiencies in the structure of our access system. So the old model for access results in multiple duplicate assessments. Someone comes into the emergency room, they're seen by the emergency room team, an assessment is done. Then they get scheduled for another assessment. They go into access, they get another assessment in access. There's this focus on the psychosocial, who's doing the psychosocial. If the person's sent to adult, maybe the psychosocial has to be done there. We're all running away from the psychosocial. And in that process, we're creating multiple assessments and often not starting treatment soon enough. So if we're doing the ideal system here, a person comes into the emergency room, gets an assessment, and that person, after the assessment is done, is being sent to an appointment with a provider who's going to use that material from the assessment, not rewrite things or ask questions. I mean, you can confirm data, and we'll be talking about that in the educational series on the new psychosocial, how to take information from the old note, and then beginning the course of treatment. So that is something that I'll talk more about how we're targeting, but it was a clear problem in the system, or is a clear problem in the system. The other thing is the excessive time spent on documentation. So when I got here, everyone knew that I was like, at least in Salinas, I kept threatening to throw my computer out the window because it takes so long to do things. And I came from Kaiser, and Kaiser is a for-profit model, and therefore they have note writing that's fast and that's efficient. So you're not spending 4 hours writing a note. You're spending 20 minutes to 30 minutes writing a note. Our goal for our system is to not spend more than 20 to 30 minutes ever writing a note. We want you to have that time with your patients, not behind a computer. In the seminar that we're going to be doing,
They're going to find you somehow.
we're going to be also working on concurrent documentation. And that may be anathema to some people, this idea that you're sitting there with a computer and you're typing as you're talking. But I think we can provide you tools that will allow you to do it in a way where you're not taking yourself away from the patient or disconnecting. And it is a beautiful thing to finish your interview and finish your note at the same time. And press whatever, submit, and it's all done. You're done with that patient. You've already done everything you need to do. Another big problem that we identified is fragmentation of care. So I saw this most clearly in the emergency room and then also on the mental health unit. And I think it is something that people see in the adult world and in the child world, but maybe not as acutely as you would see in these other settings. What has been happening is partly related to the duplicate assessment system. When people are getting sent out of the emergency room or they're being discharged from the hospital, the communication hasn't been that great in connecting people between the settings. And we're losing lots of people. And so they're cycling back. And I was trying to think, I was going to do a PowerPoint, I was trying to think of like what the image would be. And it's like a cliff. I mean, I feel like we're literally sending people out of the emergency room some of the time, just having them go off of a communication cliff. It's a void that they're entering into. When we send people to a walk-in Wednesday appointment after the emergency room, totally inappropriate. We can't send people to walk-in Wednesday. Because what happens when they get to walk-in Wednesday? Maybe they're in a really bad state that day. They sit down, they see a big line, they don't want to wait, they leave, they go home. The bad stuff that was happening happens again, they get worse, they come back to the emergency room or the hospital, or there's even a worse outcome. And the communication process, sending information, clinically relevant information from the team. Oh my God.
Popular.
Sending clinical information is something that we haven't been very good at. Regional differences, so this is part of the fragmentation theme. We're seeing that people are doing things differently in the different regions, and that creates problems for patients because they're receiving different levels of service. It creates problems among the staff because we're all doing things differently. And it's kind of unclear what the best practice is. The third big area is disparities in patient care. So in the reports, and this is something we wouldn't know about because it's not our world, but in the reports, when they investigated the patients who were in primary care, what they found was that there were a lot of very sick patients in primary care, people with severe mental illness who were stuck in primary care. And they weren't able to get over to us. And for us, it's like, we're slammed already. But there are people in primary care who are too sick to be in that system, who need our specialized services, and there are people in our system who potentially have recovered enough to move to a lower level of care. And we've moved away from being a recovery-oriented system. We're not transitioning people out of our system. Children in access. So we've got a great children's program. However, in our Salinas team for access, that system of care is completely ripped off or fragmented from what we're doing in access. In our clinic last week, we only had 8 patients show up for Walk-In Wednesday, which was great. We had a 6-year-old, a 7-year-old, and a 12-year-old, all with acute psychopathology. How many child-trained clinicians do we have in Salinas? 0. How many child-trained psychiatrists do we have in Salinas? 0. So that's a problem. Number 4, disparities in caseload. So just like there are disparities in the services that people are receiving, there are disparities in the services we're being asked to provide. And I think people have been complaining about this for a long time. We'll talk about why it's important that we set this up, some kind of system to cap caseloads and systematize it. And then the big area, number 5, that we can all agree on is that we're understaffed. We've been understaffed in access because we haven't consistently had we haven't had psychiatrists who are really present and always engaged in the process. And we also don't have enough social workers. We don't have enough clinical staff to provide the services we need to provide. So how are we approaching this? The first thing is addressing some of the inefficiencies. So have people signed up for the new universal template? Yes. What's going to happen with the universal template? What does that mean for us? In addition to it, I think, being less laborious, what is that going to do for us?
Streamline.
Streamline. Yeah. Standardize. It means that you're not going to have to repeat assessments. If our emergency room access team sees a person in the emergency room, you are not going to do a psychosocial for that person. There is one universal template. And a psychosocial does not mean anything. A psychosocial is a name for an assessment. That's a comprehensive assessment. And we've created a new form. It's easier to use. And all we're doing is asking you to do a basic assessment on someone. And you don't have to repeat it over and over again. I'm going to show you, does this thing work?
Yeah, it should. Yeah.
I can show you a quick example. Amy Miller created a really awesome video of what it's going to look like, and we'll be training you on it. The first training is May 21st, but I couldn't download her video, so I'm just going to show you my kind of low budget example that I have on my website.
Steve?
Looking? Oh, yeah.
Oh, there we go.
Okay.
Okay, so. Oh.
Just wait for the keyboard on screen.
So, under projects,
Is that you surfing?
I was about to ask.
no.
There.
Oh, cool. But my brother took that picture, and
It didn't
So,
work. It didn't
this is
work.
a video of the new psychosocial, and then using Breevy to auto-populate it.
Dave, I tried, I know I'm not very technically very good, but I tried listening to that and it didn't
Does
work on my
It
computer.
doesn't have any sound. I was just trying to
Oh,
show,
it didn't
like,
have sound.
just like.
Oh, no
just
wonder.
wanted-
Oh, thanks. Sorry.
Thank you
I
for
don't
that.
know if it's gonna work.
Well, it started showing me writing, but I,
Oh, good. Here we go.
yeah,
Just needed a
because
little
of
time.
my age, I couldn't see either. So I couldn't hear, couldn't see.
Okay. How do I make it bigger? So basically.
Yeah, that's what I saw.
There it is.
Oh, cool.
No wonder I couldn't hear. I couldn't see.
Okay. So here's the new psychosocial. You got identifying data, your chief complaint. When you type things in, you just type like .id and it populates with a bunch of stems. Here's the history of presenting illness. It's a blank box. You type in .hpi. This just gives you stems or things to think about. You don't have to use it. This is the structure for the psychiatric history. I know you can't really see anything. Medical history. Smart phrase. This is really hard to show you, isn't it?
Oh, good, it was in my eyes.
All right, so it's a bad video, but we'll send out a better video. At least you can see that the basic idea is it's a simple thing. There are 10 boxes. It's the history of presenting illness. It's the psychiatric history, the medical history, the social history. There's also a substance abuse history. There's a section on clinically relevant data, so like your mental status exam, any labs that are relevant. There's a safety assessment, a basic assessment, and a plan. That's it. It's not that hard. And we have populated it with either right clicks or smart phrases that will allow you to spit out text, either lists or narratives, to help you make the note writing go faster and remind you of the things that you need to put in there. The next thing that we're using to target the inefficiencies, how are we going to get you from spending 4 hours on an assessment to doing it all in an hour or an hour and a half, and potentially doing it with the patient in the room? I really want people to start experimenting with Breevy. We bought this software for you. Everyone has it. Just try it. It'll make things so much faster. You can use it however you want to use it. If you have some idiosyncratic style and you like to write, like whatever you want to write, you can program it to pop that out with just a single click. Educational material you can put in there and have it come out in a single click. It really can make everything faster. I use it for stuff that's as simple as like, I don't want to remember people's email address. I just have .Kathy and her email address pops up. Or my address, .address, and my whole address pops up. It's a tool. Use it. If you guys want to start doing documentation as you're with patients and you want laptops, let me know. I'm happy to try to get laptops for our clinics so that you can be out there or in a room or moving around, doing whatever, but talking to your patients and typing at the same time.
Yes.
It'll be there tomorrow. Okay. So how are we approaching problem 2, which is the fragmentation in our systems? So we're doing some things well, and we're doing some other things not so well, we just haven't figured it out. The first thing that we're doing is we're integrating it all. So access is the emergency room, it's outpatient, it's even Vienna Star. There's a part of Vienna Star that's connected to access. And when you get hired for access, I'm hoping that lots of people want to work in access. We've got 6 people that we're going to be hiring over the next couple of weeks. Access means that you work in a specific setting, but you're trained to work in all the settings. So that if we're slammed in a walk-in clinic, we can bring people over from the emergency room and they can come help. And if the emergency room is getting crushed, we can bring people over from outpatient and they can help in the emergency room. It's going to be a system that allows for clinical flow. The other thing is we are doing much more of a sign out for continuity of care in the emergency room. So Amy Haynes and I are meeting with the team every morning at 8 a.m. and we're signing out the patients. Who was discharged? What happened? Was it a good discharge? If it wasn't a good discharge, we need to follow up and do something. Did they get connected to services? Is someone sitting in the emergency room? What's going on? Do you need help? We're really trying to add strong supervision to the emergency room because we don't want people cycling back over and over again. 10 minutes? 5 minutes? Okay. All right. And we're not doing well on the exchange of clinical information. So there's not a clear system other than Avatar for how to send information among the teams. Like how does someone communicate, a clinician in the emergency room with a clinician on the outpatient teams? Or even there are problems with MHU and outpatient. We don't have a great system. Kaiser was so cool because as part of their medical record, when you finished writing a note, you could just click a button and it would, within the medical record, it would email the note and any comments you wanted to anyone on the clinical team, and it had identified the clinical team already. So we don't have that, but we're going to need to come up with something because what we have right now isn't working. Problem number 3, disparities in care. So one of the things that's been easiest to address is bringing psychiatrists in. We need to make sure that treatment is integrated with assessment and that if people need meds, even if it's their first day at the clinic, they're able to get it. We have funding to hire 2 psychiatrists. We have 2 phenomenal candidates. And I think we're getting pretty close to being able to bring them in. Right now I'm working kind of in Access as the psychiatrist. We are working on the Bienestar impact model. Do people know what impact model is?
You sent a link.
Impact model. So you can use lots of like football metaphors to describe it. They use something called the warm handoff. The warm handoff is the primary care doctor is seeing a patient and the patient says, in addition to my blood pressure and my hypertension, I'm really depressed because I lost my job. And the primary care doctor is like, oh my God, that's problem number 15. I can't talk about that right now. So the primary care doctor does a warm handoff. The warm handoff is to a social worker. The social worker accepts the handoff and sees the patient either after that visit or within a reasonable period of time. And the social worker then does an assessment and decides, does this person need a medication, need a psychiatrist, therapy, whatever. So we've embedded, or we're embedding, psychiatric teams in primary care, social workers and psychiatrists. And we're starting with Bienestar, because Bienestar is ours, and we can really control the flow of communication and information there. Why does this matter? And why am I talking about this within the fragmentation theme? Why should everyone want to send all their patients to Bienestar?
They're great.
They're great, but also we have open, go ahead. Continuity of care, I'm thinking more selfishly. Like, why do you want to send your patients over there like today? Decrease the caseload. We are opening our system. You mentioned, who mentioned the door? The big door. Access is a big door. We just took the door from being like that size to being the size of a wall. That means more patients are coming into our system. And if we don't start transitioning our patients to primary care, we're going to get crushed. So everyone should be working as hard as possible to transition those patients. We're doing a pilot. So the pilot in Salinas, the goal is to standardize access. And then once we've agreed on something that works, to replicate it across the regions so there's more uniformity. And I can tell you more about the pilot details later, but I think we're running out of time. I think it's going pretty well. And disparities in caseloads. 1 more minute? Okay, just 5 more minutes. Okay. Well, then I'll just summarize really fast. The pilot, there are a couple of key goals. One is triage. So what do we do with like an emergency waiting room of 30 patients and people being sort of like, they're sitting there, we don't really know how sick they are, maybe they're going to leave and not receive services. How do we prioritize which patients to see? And what we started to do last week in a systematic way for the first time was we had a triage script so that clinicians have a script to read if they have questions about how to screen for safety or psychosis or depression, and it's standardized. We have a patient-rated questionnaire, so people can give us that information. And then the flow was, in the Salinas Clinic, people assessed the patients, triage assessment, 5 to 15 minutes, presented the patients to me and to a supervisor, and then we decided together, is this a person who needs to be seen today? Is it a person who can be seen in a week or 2 weeks? Is it a person who actually should be going to primary care because he really just wants blood pressure medications? So there's a new, I think, element of supervision in that triage process, and we're also really working to make it a very doable thing, because triage is hard. All right. We're hiring a social worker for Vienna Star, and we're looking for someone right now. Theme 4, disparities and caseloads. We're doing okay with that. I think the best thing that we've done so far, even though we haven't created a cap, is we've identified the problems. And we're having a dialogue about it right here. I've been asking everyone in Salinas to send me their ideas for the numbers for caseloads. These are the factors that we have to think about. Number 1, there's variability in the intensity of the services that we're providing. So there has to be some way to say that a person has 10 patients who are super sick and another person has 10 patients who aren't that sick. There needs to be a way to factor that into caseload. It's not just about the number 10. The other thing is experience. A person who's just starting cannot have the same caseload as a person who's been here for 10 years, because everything takes twice as long when you're new. And then the nature of the setting. We need to figure out what's appropriate for access, what's appropriate for ASOC, what's appropriate for children's, because they're all different types of setting that require different types of care. So send me your ideas. Problem number 5 is hiring. And I talked about some of the hiring we're doing. One big thing about this is we're never going to have enough staff. So the nature of access is, and the nature of healthcare, mental health care particularly in this country, is there are not enough resources. And that's why all this is so important, that we think about how to make the smartest system possible. Because even if we spend all of our money, we spend all of our surplus, we hire tons of staff, there will still be more people. The better we get, the more people will come. The more we optimize our services, the more people will serve. And again, the more follow-up there will be, the more work there will be. So we have to cap our caseloads. We have to define what our internal capacity is. And in addition to protecting our culture and our well-being, our spirit, it allows us to ask for more resources. We can then say, we are doing the best job that we can do, and these outcomes occurred. They weren't good outcomes. Our system is optimized. We need more staff. And then we can make that request using real data. So we need to cap things. That's it.
Thank you.
Questions for Dr. Soskin?
Two comments. One is about access. As you mentioned, we should inform the patients when they come in that they need to get out somehow. Like getting into the highway, there's a time you are on the highway, but somehow you have to exit. And this is not done. So we are clogged because there are so many people coming in without a way.
Without a way out. And that's what we're building, right? Our exit is primary care. And our exit is functional recovery within our system.
And what I want to emphasize is the fact that when they get access, they also inform that they will not stay here for the rest of their life. But they had to get it because the model that I came in with was the same.
Right.
We don't know what to do with our patients because of the system.
And it's not an easy thing to do, to create a new recovery focus for our system, but we have to do it.
The second comment is about...
Wait, can I just add one other thing?
Yeah.
The other cool thing about sending patients to primary care is everyone here wants to do really good work, therapeutic work. We want to spend time with the patients who need it. And if we can reduce caseloads by sending people who are less sick to primary care, we're going to have time to do the therapy that we want to do with our patients who are really sick. This is a specialty model, and the idea is that people who are in ASOC are people that really need a lot of services, and it's going to be fun to be able to provide that. We just have to be more focused in finding those people and sending other people to lower levels of care.
Yeah, the second is about psychosocial assessment.
Yeah.
Is there any way that the PHQ-9 for depression,
Yes.
MDQ will be integrated because we'll be seeing a psychosocial assessment?
Yeah.
That is just
So
not
also,
specific.
yeah, I mean, the cool thing about Breevy is that you can take any form you want, put it into Breevy, and type .phq9, and the PHQ9 will pop out, and you can print it out and give it to your patient. You can ask your front desk staff also to do that even now, but I think that's a great idea. So, yeah.
I know you were saying about the patients going from our system to the primary care, especially things like Genostar. Will the doctor there be able to prescribe psychiatric? Because I know right now they don't, because they say everything is just for the medical, and then the psychiatrists take care of their care.
Yeah, so that's kind of why we're focusing on primary care. I mean, on Genostar. Primary care is going to have to shift their paradigm too, and they will do that. They want this to work. But Genostar, it's easier because we know Deb to send patients there, and then once we see that it's working there, we can move our psychiatry team into primary care. The idea, though, is those primary care docs are going to be less scared of prescribing Ativan or Adderall or Haldol if there's a psychiatrist that's always there on call for them to help if there are medication questions or problems. So they will be doing it.
So that would be open as well to those that are outside the system? So primary cares that are not associated with
us?
the county?
I think so. I mean, I think that
Because I think right now
we
it's very difficult for the psychiatrists to do consultations with primary care or doctors and other patients.
Oh, she's saying it's difficult for psychiatrists to do consultations, and I agree. You know, the problems in communication between primary care and mental health services, behavioral health services, they go way back. We have not done a good job of it, and the impact model is not something that like we're just making up here. It's been shown to work and tested and done well for over a decade now in other parts of the country. So the advantage of the impact model for strengthening communication is that there's a team that's embedded in primary care. So they get to know me. If I'm the psychiatrist there, they know me, hopefully they trust me. It's easier to have those conversations versus right now we're in these two separate isolated systems.
Dave, I supervised a team that did impact modeling.
Yeah.
With the psychiatrist on site and 3 psychiatrists.
Yeah.
It works great.
Nice.
It's really, really effective.
Yeah.
And it just helps with collaboration, helps keep people in the right place. The family primary care doctors are usually willing to prescribe most medications if they have a psychiatrist.
They can do it. That's great to hear. And it resonates with my experience, which is that when I'm doing consults in the hospital or even when primary care calls me, if I say, it's okay, you can prescribe this medication at this dose, it's on me, they're totally willing to do it. As long as they can write in their note, consulted with Dr. Soskin who recommended this. I'm taking responsibility or shared responsibility, and I think it makes things easier. So.
Thank you, Dr.
Okay.
Thank you,
Doctor.
Doctor.
Thank you.